the prime diagnosis is juvenile idiopathic arthritis. The prime diagnosis is here. Juvenile idiopathic arthritis. The prime diagnosis is here. Juvenile idiopathic arthritis. The prime diagnosis is here. Juvenile idiopathic arthritis. Right knee. Yeah, and from this time we started treatment with biologics. And from the next days, 48 hours, see different exposed area from qualitative, from inflammation. In this case, from thermography inside bedside point of care, demonstrated a response not only from the opinion from the patient. The scale is 3, the scale is 4 or 5/10. Now we can see the different areas from the quality imaging. Again, Kane, see the pain and demonstrated the response of effective treatments. It's not only subjective response. Yes, my pain is too much slow now or too much little. No, it's real. You can see that after, before. I think the most important approach from thermography is, in this case, is demonstrate areas. Marcus, what do you think about that? Yes, about the point of care thermography, inside the limitations. Perhaps this is the future of a treatment response in real time, not film.
I'd like to add something to this if I could. The idea of monitoring the response to treatment using thermography really opens up a whole new way in managing patients, because normally we're looking at symptomatic improvement. Does the pain level go down? Does range of motion improve? Functional changes? These are all good things. But now we can see the neurophysiology working at the same time. And it raises the question, when a patient's getting ready to discharge after, let's say, a physical, they've had an injury and they've gone through rehabilitation and physical therapy, at what point are they ready to be discharged? Now, we could do range of motions and orthopedic tests, and we can do pain level scores, and those are all good things. But how about something more sensitive like thermal imaging to see how the overall physiology is working? Because that could show us a limiting factor that could tell us this patient's still not ready. They're susceptible to re-injuring themselves. And if we don't take care of this a little more comprehensively, they're probably going to end up with the same injury later on or something worse.
Oh, yes, yes, it's really, Kane, if the question, your experience about point of care, you can use it, or you only use it laboratory imaging thermography. I don't know if you want experience about point of care.
I don't have a lot of experience with point of care yet, simply because I read laboratory studies and I'm not actively treating patients. If I was actively treating patients, I would be doing point of care all the time in addition to the laboratory studies. So I have a unit right now that I'm playing with, that I'm just working on with friends and family, just to see what we can see. So, for example, I had a friend of mine come over with some right arm pain, and nobody was able to really figure out what was going on. I thought he might have thoracic outlet syndrome. And I looked at his arms with point of care. I didn't see any temperature differences, but then I was able to put him through orthopedic tests right then and there. And when I put him through the orthopedic test, then we found the problem. And point of care is a lot more conducive to doing that kind of analysis, because I can get in there, I can move the patient, I can touch them, I could read through the variables because I'm creating them. And it's conducive to the application. That I read for, I don't send me point of care images to be read professionally, because I'm not there with them, so I can't read through all those things. That's for the doctor to do in the office by themselves. And I think it's a great application. But if you're looking to have something professionally read, we need to have those variables controlled so I can give the best possible explanation for things without worrying about laboratory variables.
Yes, yes. I think the thermography in point of care is most important for critical patients from not move. Perhaps we need now a scan, yeah, but no disclose from the moment. Because with other patients there, those critical patients from the first screening detects. You can read, you can hear me? Okay.
Yeah, I mean, I think there's certain applications that are just very conducive to the point of care. All of the stuff that, you presented with the AAT in the surgical region, how do you do a laboratory study with surgery? It's impossible. Yet you're getting real-time data that's critical for the care of that patient using point of care. So in my world, and I came from laboratory studies. If you would have talked to me 5 years ago, I would have been, no, it's only laboratory. That's all you can do. Now I'm seeing that there's a place for each. And it depends on what data you're looking for, what's the specificity of the data, and how are you planning to use it. And there are very clear applications where point of care is going to get the job done much more efficiently, much faster. And there's some applications where, it's better to have those laboratory conditions in place just to make sure your data is as clean as possible. So the point of care is better handled. It's really exclusively for the practitioner domain, someone in the treatment room or in the exam room. The laboratory studies, that's something that can be done by an outside technician, read like an X-ray would be done. It could kind of go into analysis and come back. But I wouldn't want a technician to go and just start point of care because they're not going to know what they're looking at and they're not really going to understand how to work with that information.
Yes, it's strange because perhaps the sensations from the teams, medical teams in neighborhood area from working now, the first thermography's data is Sergio, it's hitting. It's a hitting. Ah, it's casually hitting. But now the clinical data is more clear because not only the hitting one time, two time, or three times. It's even the same information. It's not clear because for the others medicals, now first in thermography uh, for this is the way or not, it's the way. For all inflammation, post-chirurgical, burns, catheters, uh, the inside mind from the young medicals can see inside rooms. How is that? Thermography. Oh, how you explain this point clinical and it's the most important for sensibilization next generations for medicals from the future or the present. And see the Marcos and talk again. What do you think about it, Kate, about this one? The sensibilization from the next generation from medicals using in your mind thermography. No touch, no ionizing ionization, and no adverse effects, and fast screening and wait for treatments, for example.
Well, obviously, I love it. That's why I'm here. I think it's I think it's very exciting. I think there's so many possibilities we haven't even begun to explore yet. It's nice that we're getting the availability of AI and new ways to use thermography and new ways to analyze it. I think we're at the very tip of the iceberg as far as what we're going to be doing with this thing in the next 5 to 10 years.
Yes, yes.
I'll let you. I'll let you test that one out, Dr. Marcos.
Well, this is really exciting, Marcos. You talking about that, but it's amazing because think about it. The snakes see the head and see the optical imaging, and less research about snakes. Approximately, the resolution of the infrared imaging for the snakes is about um, uh, I don't know what uh, tools used for interpretation. I don't know, inside in, in ocular or I don't know, but oh, I'm problem connect. Okay.
Sure. I just want to say thank you for inviting me. It was always great to get together with you and Dr. Sergio. I'm just always amazed at the places this profession is pushing forward into, and it's exciting to see all the applications. So thank you for having me, and I look forward to further conversations.
Okay, I am excited for this talking about and sharing experience, opinions, perhaps some coffee thermology. I like that, love that. I think it's too much to repeat, perhaps. It's crazy. It's amazing. Love that. Thanks so much, Professor Marcos, Professor Kane, for your time and talking your experience. We can see the next